Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the Bioskills of the Northeast studio in Fall River, Massachusetts. Today we'll be discussing women's health with Dr. Kishore Lakshman. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all your financial needs. Visit Bay Coast Bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and of course, 5-star reviews are always greatly appreciated. So first of all, before we get into this, and there's so much interesting stuff we're going to talk about today. We're going to talk about women's health, but particularly, it sounds like hormone replacement and sexual health in women. Correct.
Yes.
So tell us a little bit, in the audience in particular, about yourself and your background and how you got into this and what your interest is.
Yes, absolutely. So I'm Kishore Lakshman. I'm an endocrinologist working here at Primacare. This is my third time coming here to you guys, so I feel very privileged. So thank you for the invitation. We covered men's health first, and then we covered transgender. And today I'm particularly excited about women's health because it's less talked about, underrepresented, under-researched.
Absolutely.
And there are a lot of myths, especially regarding hormone replacement therapy in menopausal women and women's sexual health.
Yeah, I'm really interested in the hormone therapy aspect because that's changed so much over the years.
Absolutely. And there's so much misinformation, and I'm hoping I can debunk a lot of those so women feel, empowered to talk about it more.
Why is it less represented?
That is so if I were to get into the details of that, I will in a second, but going back to, I know you had also asked me how I got into this space. Before I forget that train of thought, I will come back. Research, I also call myself a clinical andrologist because of my interest in androgen hormones, especially testosterone. So that passion originated for me in the very early years of my training in endocrinology at Boston University.
Okay.
A lot of the clinical exposure that I had, as well as clinical research, was very tied into testosterone and the mechanisms of what it does and how it does in both men and women. So after, going knee-deep into research and getting a lot of knowledge from that, I had the opportunities to apply that in clinical practice. So men's health, treating sexual dysfunction in men, low testosterone states, is kind of where things originated for me. So I brought that to the community, and I'm proud to say we have a pretty well-oiled machine as far as men seeking hormone replacement. We have very good protocols in place. Thank you for the support of the medical community, including yourself. And I think I realized as I went down that path, it was very organic for me to go into the women's health space because the guys that I treated would come back to me and say, hey, listen, we feel pretty good at this point, but our partners need to be optimized. What can you help them out?
Right.
And that's how I organically kind of went into the space, and I was doing that. And I learned it. To this day, I learned so much from my patients, as much as I learned from reading articles and textbooks. So that was a great space to get into. And now where I feel I can treat the couple as a unit, talk to both of them, see what needs to be done, and get them to a good place about sexual health in particular, which there is so much stigma around. So destigmatize that, give them a warm and welcoming space to talk about their health. And because sexual health is a couple's problem, it's not an individual's problem. So it's nice, and I feel really honored to be able to offer both that help. If one person is suffering, the other person likely is also. And going back to your question about why there is so much misinformation, so I have to track back a few decades. So back in, say, the 1990s into the 2000s, hormone replacement therapy was mainstay for menopausal women. That's what we gave. That's what we did. It was a knee-jerk reflex. Somebody is going through menopause. You replace them with hormones. And we have a wealth of data in that period showing how safe hormone replacement therapy
I
is
recall
for
those
women.
days. And then it all
Yes.
changed.
Exactly. So not only in improving their quality of life and their menopausal symptoms, but also deeper things like primary prevention of cardiovascular or
Correct.
disease, and prevention of osteoporosis, maintaining bone health,
Right.
perhaps reducing the risk of breast cancer. So these were some of the valuable goals to also achieve in addition to relieving their symptoms and improving their quality of life.
Right.
And then the hormone ship sank in 2002.
Right.
One of the largest studies to this date in the United States, called the Women's Health Initiative, which was sponsored by the National Institutes of Health, conducted a study. Their goal was to answer two questions. Is it truly helpful in preventing heart disease in women that take hormone therapy? And number two, what does it do for breast cancer risk? In 2002, they found some preliminary evidence that there is an increased risk of heart attack in these patients taking HRT. Also, it may increase the risk of breast cancer. So very prematurely, they held a press conference in Washington, D.C. It was dramatic, sensational news, right? And negative news is always sensational. They announced that, and overnight, just like that,
It was like a switch turned off.
turned off, exactly. So hormone replacement therapy abruptly came to a screeching halt. Nobody wanted to take it, people that were on it. So this damaged both the society and the medical community. Patients didn't want to take it. They had this fear of life put into their head.
Exactly.
And the medical community said, back off, I'm not doing this completely. Yeah. What happened later or after is little known to the society, to women, and also to the medical community. So what happened later? Let me talk about two basic flaws that is often has to be addressed when we talk about what went wrong with these findings of the Women's Health Initiative. So two big categories. There's many, but for the sake of simplifying things. One, the women that were in the study were older women. The average age was about 63, 64. Okay. Much older women. So this is a big contrast from a woman that is entering into the menopausal transition in her mid-40s or late 40s, early 50s. Sharp contrast. Number two, the hormones that they gave were different hormones. So they gave Premarin, which is from a pregnant mare. It's urine, hence called Premarin. So that's considered that's not bioidentical. So it only has some similarities to the estrogen that the human ovaries make. It has a mix of other hormones too, a few others. In other words, the estrogenic exposure that Premarin gives to the human body is wide. Because it has several types of estrogen.
It's not bioidentical.
It is not bioidentical.
And that's a key part.
It is exactly
The issue.
And then the second part is the progesterone that they used was synthetic progesterone. Again, not bioidentical, synthetic progesterone. So with these, if you go back to the age of the women, the average age being about 64, they have been in menopause for way over 10 years. So their bodies have taken a hit from being hormone depleted for so many years. And as a result, their risk profile is very different from a younger woman in the 40s or early 50s going through menopause. So that was one flaw. Therefore, it was not surprising that they have a baseline higher risk of getting heart disease as such. So it wasn't surprising that they found this association. Same with the risk of breast cancer. As women get older, and especially after they've been hormone depleted for so many years, they had a higher risk of breast cancer. And something has to be said about that risk of breast cancer too. It was over-exaggerated. There's different risks when we interpret statistics, and that risk was grossly misinterpreted. The second part is hormones. So these hormones that those women got are very different from bioidentical hormones that are widely prescribed now. So as a result, the Women's Health Initiative overgeneralized. They concluded that all women are made the same. all hormones are made the same. That is not true. And they also particularly excluded postmenopausal women who were symptomatic, had hot flushes and other symptoms. That again is insane. How would you do that? So therefore, they didn't have a lot of positive things to report. If they had included women that were symptomatic and you administered quality of life questionnaires before and after, you would also have good things to talk about. But they undermined the good that came out of it, such as quality of life scores, which we didn't have the data. Here,
so it was a very biased.
It was a biased study. Right. So now that we are, 20 plus years from now, over the years, the Women's Health Initiative has retracted a lot of its findings. So much that now some of the sub-analysis showed that so there were two arms in the Women's Health Initiative, women that got estrogen only. These are the women that did not have a uterus. It had been removed for various reasons. The others that got estrogen and progesterone for protection of the uterus lining. So they concluded, can you believe the paradox? They concluded a few years later that in the estrogen alone arm, estrogen replacement reduced the risk of heart attacks. And number two, that progesterone and the other concerns that also came up were risks of blood clots and strokes. They concluded that it does not increase the risk of blood clots and strokes, and it improved or it lowered your risk of getting a heart attack. So complete opposite.
So many went without a needed therapy.
Yes. And then they also talked about the fact that combined therapy did not increase the risk of breast cancer.
Okay.
If so, that risk may be coming from the synthetic progesterone that they used. So that we understand now. The risk is probably mediated by synthetic progesterone, which we don't use anymore, and it's a very small risk. But estrogen gave you so many positive things.
It's kind of similar to the whole birth control story from years ago.
Yeah.
You know, how women would have, they might have deep venous thrombosis, pulmonary embolism, et cetera, in these events. But ultimately, the hormones that they were on, one were very potent, high potency.
Correct.
They were at doses we don't use now.
Okay.
And
exactly.
It is somewhat of a similar story.
Yeah.
It's
a parallel to
it's parallel at least. But the damage was unfortunately done with that study, and it was very public, and it's taken many, many years to turn the ship around.
You're still doing it. And these positive findings did not get publicity. They did not hold a press conference.
That's the way it always is.
So yeah, exactly.
They never retract. When they put a retraction in the paper, no one reads it. It's always,
So
big article.
Yeah. So what has happened in the last 2 decades, right? After this nuclear explosion happened for hormones.
Right.
I should say, as such, hormones, there's a sense of shame around hormones for women, which I'm understanding now from meeting so many patients, evaluating them, and also talking to my women in my family. They say this stigma. I think in general, there's a stigma around sexual health, and then there's a stigma around women's hormone. There's almost a sense of shame from birth to later. If it's you're going through puberty, it's like, oh, I think that might be that, she probably is getting through puberty, so you blame everything on, it must be her hormones.
Right.
And once you get into puberty, it must be that time of the month. So you go through that and you rationalize things or look at it from that angle.
I never thought about it. It's very fascinating.
And pregnancy is a whole other thing, right? It's a chronic hormone problem.
Right.
She's a beacon of hormones. Okay, that's hormones. And then there's postpartum. Oh, there's a hormone drastic shift. So again,
hormones get blamed for
it must be her hormones. Yeah.
It's
and
interesting.
Then when they're going through menopause, yet again, it must be her hormones. So there's a sense of shame associated with it almost for women. And that's what I hear, which is why a lot of women tear up when they're talking to me about this or being given a platform to actually talk about their hormones.
They don't feel comfortable doing it because as a society we have we blamed everything on hormones really in some ways.
And like men's health is so well advertised and it's out there and it's mainstream.
All my male patients want testosterone.
Yeah,
exactly.
They all want,
whether it's low or not. They want testosterone.
Yeah. And do I ever say the guy's grumpy? It must be his testosterone. We never say that, right? But for women, it's
kind of like hidden a little.
Culturally too, right? Women just think, it's menopause. We just got to go through it. Moms don't talk enough about it to their daughters. Everything is just
Interesting.
It's like a touchy subject.
I never thought about that aspect of it,
Yeah.
societal aspect,
Yeah.
how we have addressed these
exactly.
issues, but
So
it's an important piece.
women
The
became
commercials that are out even today, it's all about men. You know, it's like you don't see the same amount about women.
You're right.
Yeah.
You see testosterone ads everywhere,
Yes.
and you know, as for erectile dysfunction, et
Exactly.
cetera. But you're right. You don't see almost. I don't think you see much out there at all for women,
Yeah.
sexual health or
No.
hormone replacement or whatnot.
exactly.
So true. I didn't think about that, but it's very revealing.
Yeah.
Same thing goes with research, education, platforms, lobbyists, to promote that. So what happened, the already sort of, the stigma around it for women in general got worse. So they said, okay, you're not talking about it. Just to give you some statistics, 80% of women entering the menopausal transition experience symptoms, 80%, which hot flashes is like the hallmark. Only about, before this the Women's Health Initiative crisis happened, only about 25 to 30% were seeking help for going to their doctors for hormone.
Because they were taught this is part of the natural aspect of life, and that's what happens.
Just don't say
Right,
anything,
yeah.
move on.
Yeah,
And
which is unfortunate.
that dropped to 2 to 3%. So now only about 2 to 3% of menopausal women actually seek help for menopausal symptoms.
Wow.
The prescriptions for HRT fell by about 80% after the Women's Health Initiative. Then when you look at the medical community, that dropped significantly. Doctors that were prescribing, only about 25 to 30% of doctors were actually prescribing. Even worse, in the last decades that have come, new graduates in medicine, family practice, obstetricians, they do not get trained sufficiently in menopausal hormonal therapy. It might be like a chapter in their residency. And I have firsthand information. A family friend recently graduated from an OBGYN residency program. She's taken on a big girl job in a couple of months. And I asked how much HRT was taught. She paused for a minute and she said, nothing, barely anything, she said. The only exposure was when she was preparing to take her boards and she was obliged to cover that chapter in her book. So do you see the damage that has caused even to the medical community, so much that there's so much inertia in the community also to treat or talk about it or even bring it up during a normal conversation?
There's a lot of physicians that still believe that everything that was put out there 20 years ago or more now, right, is true.
And
Interesting.
yes, so there's that. So, and then there's who owns this space, right? Do OBs own the space? Do internists, family practice doctors own the space? Do endocrinologists own the space? So everybody is blissfully assuming the other specialty does, and there's fewer OBs than, I think that there was some statistic that to every OB there are 10 or, I don't know, internists, family practice, like the ratio
believe that.
is huge.
That's probably
So,
accurate.
so I think it has to be a shared responsibility in the medical community to at least talk about it,
Right.
and then, I'm happy to see them and treat them, but more conversation. But again, when I say shared responsibility, shared between the medical community and patients, women should also see.
Isn't it amazing how appreciative patients are when you do talk about any aspect of their, things that they've been suffering in silence with?
Yes.
And sexual health is often one of those issues. It's amazing. It really is.
And too, like as a woman, like when I go to my primary care physician, like there's other issues I'm targeting like maybe 3 issues that I want to go in, and it's like all the other stuff. It's like you don't think about it, or you don't have time for this unless you're experiencing a really
It always
bad.
gets put on the back burner in primary care.
Yes.
Because there's so many other things that we need to discuss. So, you're looking at talking about the diabetes and the hypertension and
Exactly.
and the things that, are important,
Right.
but this is important too.
Yeah.
But where do you find the time?
Well, yeah, and in my mind, even as a nurse, I'm like, oh, I have to prioritize. I know I have 15 minutes with you. I know if it was important, you would stay more than that.
16 or 17.
Even when you go to your OBGYN, what are you going for? Your like mammogram and like
Yeah.
it's all like tick the boxes.
Yeah.
And it's like you don't have these conversations.
But these are conversations you can't really do in a 15-minute visit where you're
No, that's
or then depending on who, like sometimes you have the rotation. You know, you might have this doctor at a certain time and then you have the NP or whatever.
right.
And everyone, like there's nothing concrete. Like
Yes.
you might have all different ideas and then you're like, well, forget it. I'll just wait.
And then how do you bring it up, right? So that's the way I think that the space that we provide, they know why they're here. I know why they're here. So there's no small talk. We get right into it. And obviously maintain some levity around it. You know, we're just having a good time. We talk about it. That's what we do in our offices.
Because I can imagine this conversation, right? The husband's like, hey, honey, we're going to go see this doctor, you know, come on with me. And then they're both sitting there, or they might, you know, both really want to go see you. And it's like, how do you start?
How do you, So today, I just remembered, this is fresh in my mind from this morning, a new consult. She had come in, she's in her 60s, for sexual dysfunctions. She'd heard of me and she said, wow, this is amazing that I can talk to you about it. And we had a lengthy conversation. At the end, she teared up a little and she said, just talking to you, I feel lighter and I feel so much better. Whether you treat me or not,
That's wonderful.
I'm going out of here. I needed lab, so I said, come back. She said, I feel good. Just talking about it. Thank you for listening. So I think it has a profound impact.
Yeah.
And what else changed? The big change, what else changed is how we manage, or I should say not manage, menopausal symptoms. So the community started to look for non-hormonal ways to deal with menopausal symptoms, which actually made them worse. So I have just a list for reference. This is the menopausal rating scale you probably have seen. This is a standardized list of symptoms that is published out there, so women can take a questionnaire. There's different symptoms.
I've never seen this in my life.
Okay, yeah. So the standard scale has 11 questions. And I added 7 more because they come up a lot. So the bottom, like questions 12 to 18 are what I've just added out of what I see in practice, and there's a correlation. So let's just take, for example, hot flashes, right? The cardinal symptom of menopause. So can we give hormones? No, because it kills people with heart attacks and causes cancer.
That's what people think. Right?
Yeah, that's what they think.
Yeah.
Although I have to say, a little segue to that is, the biggest fear in women, there was a survey where 2 things. One, what happens when menopause hits that causes all women across all ages, or once at least entering menopause, a lot of anxiety. And the second is, what is my chance of getting breast cancer? And a survey showed those are the top 2 fears. Heart disease is the number 1 killer of men and women, right? But yet people don't think about that. And again, here, that's a risk factor from not getting HRT. So for hot flashes, then there's a lot of research in coming up with novel medications, or SSRIs, for instance, are treated.
Zoloft, black cohosh, all of that.
Yeah, but again, what do SSRIs do? They have a lot of sexual side effects, especially in women that are hormone deplete. Somebody that has intact hormones may not have those side effects as much. But when you're giving SSRIs to a hormone deplete woman, they're going to have sexual side effects. Delayed, absent libido, inability to orgasm, those type of symptoms. So you are, again, treating the symptom, not the cause, and you've added on a new problem.
Right.
And they are not very effective in treating hot flashes either. So that's one example there. Other examples, again, anxiety, depression, these are, again, very expected mood changes that come with menopause.
Mm-hmm.
So again, you're giving an antidepressant, they may help, but they're bringing up other issues, especially with sexual symptoms. Let's go to, let's see, bladder problems. That's an important one. So to take a few steps back, so with your menopause, this is a quality of life scale, this one particularly. It's only talking about the various quality of life things. So the top among that, if you look at just quality of life, would be your sleep. So sleep is significantly impaired in women that are going through menopause. And progesterone, that's the hormone that's the driver of sleep. So progesterone is this really neat steroid that has calming, relaxing properties, which is why the lack of that can cause significant issues, falling asleep and going to sleep. So women that have sleep issues, even without hot flashes, again, end up getting prescribed trazodone or Neurontin or other medications. Again, you're just treating the symptom, not the underlying cause. You can get other issues from that. Cognitive issues, that's another big thing that perimenopausal symptoms talk about. Word-finding issues, memory issues, mental fogginess. Women pride themselves in multitasking, but they feel that talent is dissipating a little bit. I went into the laundry room. I forgot why I came here. So that's something I hear quite a bit, and it's like it's a huge talent that they've taken pride in all these years, and then all of a sudden it's gone. And then some of the other things like bladder function. So with testosterone, with menopause, the hormonal deficiencies can cause systemic effects such as hot flashes or mood issues, irritability, cognition. It can even cause joint aches and pains, sleep issues. And then there's another separate category of the genital symptoms that they cause.
Mm-hmm.
There's a scientific term for that, genitourinary syndrome of menopause. So that occurs specifically in the genital areas, and that is from the lining of the vagina getting depleted from estrogen and testosterone. So as a result, you have significant dryness, pain during sexual intercourse. The bladder and the urethra, which is the tube sort of that carries urine out, also have the same receptors. So when you have a deficiency of hormones in those areas, you get urinary symptoms, frequent urination, frequent urinary infections, incontinence. So when these symptoms happen, especially the urinary symptoms to women going through menopause, I've seen a lot of women getting medications for bladder overactivity and things like that, where again, that's just...
Which have a whole host of other side effects.
Side effects, exactly. But it's deep down the root. It's the hormone deficiency that's sort of really the problem here. And then now, more lately, we have some FDA-approved non-hormonal products for addressing low libido in women and also for addressing hot flashes. I can get into that a little bit later, but those are not very effective, expensive, and then come with side effects also.
Okay.
So I am just trying to, in summary, what are the different ways that we have gone after this happened and after bad press was released that hormones are not good?
So what do we know now about hormone therapy as far as we can debunk pretty much everything from the Women's Health Initiative at this point?
Yes.
We know that it's not a cause of premature heart disease.
Correct.
Right? How about the breast cancer risk?
Reduces. So when you give estrogen therapy in a menopausal woman, perimenopausal women, it actually, there's enough data to show it reduces the future risk of breast
So those were the two negatives that were really publicized.
Yes.
And then on the other end, we've got all these positives that can occur, right? Improvement in sexual function and in sexual health, reduction in hot flashes, reduction
quality of life,
improvement in quality of life, maybe reduced anxiety, it goes on and on.
Yeah.
But ultimately, it's a quality of life issue.
Quality of life issue. And I think there's a deep economic impact to this too. So when you left, so since 2002, you just stopped treating menopausal women completely.
Yeah.
There's enough data to suggest chronic issues that came out of that and the burden that had on the medical community. So to start with osteoporosis, the big one, right? So when you've left a woman untreated, under-replaced with hormones from her mid-40s or early 50s for that many years, huge rise in the incidence of hip fractures, which comes from osteoporosis. So that's the economic burden for the community and for the workforce too, if you look at it that way.
And when you talk about quality of life after quality of life is so diminished.
Yes.
And risk of death is so great.
Risk of
within a short period
exactly.
of time.
Heart disease, huge. You know, women have more heart disease than men do. Again, is this the explanation? Likely. Dementia also. There's a lot of literature showing that, again, dementia is more prevalent in women than men.
Right.
Why is that? Does this offer an explanation? Likely.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
So how come this is not a standard of care now? Like in 2025, shouldn't it be a standard of care?
Unfortunately, it's not. And I think it's both ways. It's that inertia in the medical community, lack of one specialty or one...
There's no ownership.
Yeah, no ownership. No one's claiming that to be their territory. They know about it, but they don't want to publicize or just make that standard of care. And again, that's being made okay because women are not seeking HRT, right? Mm-hmm. If they were demanding and saying, I want to talk about my menopause, I need to say, there might be an urgent need in the medical community to meet that.
And that goes back to probably how they've thought about menopause and hormones through their whole life. It's passed down through society, right?
Exactly.
Yeah. It's so fascinating.
Textbook definition of menopause is when you've gone 12 months without a period. Mm-hmm. Arbitrary clinical definition. Who came up with it? Why? Nobody knows. So the understanding menopause itself is very confusing, is what I understand from talking to my patients. What is menopause? What is perimenopause? So perimenopause is that transitionary period between when you start developing those symptoms up until when you've gone into menopause. And the clear definition is 12 months without a period. And then from that point, you become postmenopausal. But the area to focus really is an average of 10 years. So women are spending on an average a decade of their life in perimenopause. So from your mid-40s to your mid-50s. The average age of menopause is around 51 years, right? So from your mid-40s to your mid-50s, you are these are all the symptoms that you have. And this, for many, that might be the peak of their careers. For many, that might be the peak of their parenthood with kids and so many things. So it is a big problem in a woman. And then I don't think most of them going through menopause are counting those years. They're thinking, oh, it's probably going to fade. It's probably going to get better. Oh, I missed my periods for 10 months. I'm probably in menopause. Oh, I just got a period. Oh, does that mean I got to start counting again for 12 months? So if you go by that definition, and then what about those women that don't have their uterus, right? The uterus is removed for whatever reason it may be. So one other thing that happened after the Women's Health Initiative was an increase in the amount of hysterectomies, and because when women had irregular bleeding and periods and things like that, removing the uterus was a convenient thing, I guess. Yeah. And many times, might as well remove the ovaries. So they were almost treated like spare parts. You can just get rid of them. So then what does that do? That makes it even more confusing. When you have periods as an indicator of defining menopause, for those women that don't have an intact uterus, how do you know? So you just think this is life, that you're not able to sleep, or you're getting a hot flash, or you're foggy, you can't multitask, and you're missing work. So there's that. It's too long to not be taken seriously. It's a good 10 years of a woman's life.
I think a lot of people they associate menopause. The main issue is just hot flashes, and they say, oh, you'll get over that eventually.
Yeah.
But there's this whole other host of issues that you raise that people don't think about that are so important, so critically important.
Yeah,
exactly. And then you're treating all the symptoms, you're never getting to the root cause.
Correct. Exactly.
Like you said, it's like a patchwork quilt that never comes together.
Exactly. And then again with sexual dysfunction, so many ramifications from that, correct? It's only going to compound your depression, affecting partner relationships.
Right.
And it's only going to be a spiral at that point when...
And some people don't associate all these symptoms with menopause. They just think, oh, it's the aging process. Or, they're not thinking, geez, maybe it's just estrogen.
Yeah.
You know?
So go ahead. Yeah.
No, I'm so fascinated in how we
I'm mad.
how we
You should.
we've kind of treated women over the years compared to how we treated men when it comes to hormone depletion.
Yeah.
You know, it's very interesting to me.
Yeah.
I mean, the way society has looked at this, and it's fascinating. I never really thought about it as I am today.
Yeah. I got more insight in just from talking to my patients, and also just it opened up, it gave me the courage to talk to my mom about it,
Right.
my wife about it, to my mother-in-law. Like, what did you, and it's eye-opening to me. And because there are a lot of cultural aspects to it too, right?
Well, you realize, you know, we are a very misogynistic society
Yeah.
in many ways. You
There's
know,
no doubt about
it's really
Yeah.
fascinating. So I'm glad that there are people like yourselves who are kind of
Thank you.
running with the banner.
Yes,
here.
yes,
thrilled.
that's what I
That's
wish
what I
to do.
Can we talk a
Especially, I'll say one thing.
Yes, yes.
You know, like when you're talking about the cardiac disease, especially in our area that has such
Yes.
We have so many
So-
diabetics.
Yeah.
So right now we're going to have
Yeah.
higher.
so prevalent for
Yes.
cardiac disease.
Yes.
And it's like if there's one area that should be focusing on this, it's our area.
Correct. And when you have a hormone-deprived women for that many years, the body composition changes that occur
was just gonna
in
ask
favor
you
of
that.
depositing visceral fat, reducing lean mass, more systemic inflammation, higher risk of diabetes.
Right.
Everybody gets put on statins, right? And then the
Yes.
wisdom is lower the statin, the better. But
You're telling me my life.
sex hormones are derived from cholesterol.
Right.
Testosterone, estrogen, progesterone, they're all derived from cholesterol. So that doesn't help here, you know, because the lower the cholesterol, the better is not good for your natural production of sex hormones, because that's where they come from.
So if you've been, like, say, someone in their early 60s, you know, hasn't been taking estrogen, and all of a sudden, you know, here's this.
Yes.
Is there a benefit now to going on it after?
Yes, I can definitely. Do you want me to address that, or is your question really?
Well, I wanted to also. This time is going by so quickly, and there's so much to talk about. But I really wanted to focus a lot on the sexual health aspect of
Absolutely.
of this too, because I think that's something that so many women are afraid to open up about and talk about.
Agree.
And you're here to help women with this. So I'm
Yes,
hoping you can
absolutely.
talk a little bit about.
I'll talk about both. Both your questions
Okay.
can be answered together, I think. The three key players, sex steroids, are testosterone, estrogen, and progesterone. Testosterone is sort of the king of these hormones, even in a woman, believe it or not, because estrogen is derived from testosterone. It's a byproduct of that. So they're key hormones. So each has a unique role to play in a woman's health. So estrogen is the key player of your vascular health. It controls temperature regulation, so hence you have hot flashes and mood issues. Estrogen is very important for your brain physiology, key component of it, which is probably why you have those cognitive issues and risk of dementia, Alzheimer's from estrogen deficiency. Progesterone is your key sleep hormone, very vital for your sleep. And for a lot of people, men and women, if you get that sleep right, a lot of things fall in place.
Absolutely.
It's an important part of that. Now coming to testosterone, it's your sex steroid. So it is estrogen in a woman that only takes estrogen and progesterone. It's going to help with sleep, some of the quality of life issues. But for their sex lives to be enhanced, you need testosterone. So it controls libido, controls arousal, sexual fantasies, just overall satisfaction. So you need that. That is a direct testosterone effect. And non-hormonal therapies that we may be employing, like we discussed, is only making their sexual symptoms worse. To cover your question, the recommendation now, there's almost like a time hypothesis where you want to start replacing a woman that is going through menopausal symptoms, the earlier the better. When the benefits of the HRT or hormone replacement is most seen when they're early in menopause. So don't wait. Seek help early on. And the protective effects of HRT are also seen when HRT is started earlier. The protective effect of estrogen and progesterone on the heart, the protective effect of it on your sleep, and reducing breast cancer risk.
Okay.
There is the wisdom that's growing in the community now is that in older women, the ones that are above 60 and have been 10 years out since menopausal symptoms started, they are the ones that may be at risk of an increased or may carry an increased risk of heart disease.
That goes back to the study.
To the study, older women had been hormone deprived for so many years, so all their blood vessels had those changes already, unfavorable changes. So hormone therapy can still be offered to somebody that is over 60, but after careful discussion, after risk assessment, and seeing which hormone needs to be replaced. It is not all or none. It is which one do you need, right? A 60-year-old woman is likely not going to have hot flashes by then. So estrogen is out of the picture. So that's okay. You don't have to give them estrogen. If their sleeping is significantly disturbed, you may consider adding some progesterone. But what they will likely seek help, like the 61-year-old that I saw today, is sexual dysfunction. She told me that her husband passed away a few years back, but during their life together, she had absent libido, nothing, but she, quote unquote, made him happy. But now she has a new companion who's, she feels wanted, she feels scared for, and she wants to, get more intimate. So she's in her 60s. So for her, testosterone replacement is a good option for her. Again, after having, that is a field that's still emerging, testosterone in women. We have identified that as a key hormone that should involve discussions around menopause. It has to go with the other two.
In your experience, are women less likely to take testosterone because they fear like maybe facial hair or...
Good point. Yes, they do. That's the number one question that comes up. Will I grow a beard if I go on testosterone? So as a professional trained in hormones and endocrinology, it's my job to do it safe.
Okay. Where
you are maintaining a certain target range, where you are definitely treating your symptoms. There are no clear guidelines. For men, there are clear guidelines. A low T is a T below, a testosterone below this. When you treat them, try to get them here. We don't have clear definitions for women. So to a large extent, we are titrating medications, whether it's estrogen or progesterone or testosterone, to their symptoms, not to labs. You're making sure their labs are okay, but you don't have standard targets to treat. So that is the question from women. Will I? So then my response is no. We are going to start you on conservative treatment doses. Okay. We will slowly titrate them based on how you feel. Labs will be monitored. They may grow a little hair on their face, perhaps, but most women tell me they're experts, professionals at hair management.
Yeah.
So if they can get their sex lives back at the cost of plucking some extra hair, we'll sign us up. So it has to be done carefully. Unlike there's been a explosion of wellness experts, experts in the community, our own community, that offer hormone replacement very easily. And there, it's sad, but it seems to be a profit over purpose model, with ads saying, get your testosterone treatment at your first visit or we'll give you your money back. I mean, that's not how this needs to be advertised in women. It's a space where you talk about it. These are your options. What is bothering you the most? Which symptom is bothering? Some may come in with all issues. Some may come in with one issue. So then you want to tailor your approach to that. And then just kind of,
it can't be a cookie cutter approach. And that's the problem with some of these other clinics. And they provide often very high doses of some of these hormone
we have packages, this is not a vacation package that you choose and get other things added on, a free vitamin bag if you get packaging. I mean, that's not like that.
Right.
So now how we feel about hormone replacement is we feel that estrogen is safe to replace bioidentical estrogen. That's what we choose, not the conjugated or the ones derived from horses like Premarin that they used. That has gone out of fashion. So we get that as pills or we get that as a patch.
Okay.
There's two options. There's some situations where one may be better than the other for women. That is if hot flashes are their primary symptom. Progesterone, and I have to go back to say that estrogen is also available in other formats. They do sublingual tablets. They do pellets. These are not FDA-approved products. They're products that have come about by through compounding pharmacies. I have reservations with those products. I usually stick to pills or patches when it comes to estrogen. Progesterone too comes in pellets. There's many fancy ways of giving it, but just what's worked for me is to give progesterone in a capsule form. I have my patients take it before bedtime because remember it has that relaxing, calming effect, so they sleep better. And then when it comes to testosterone, again, there's many different ways to do it. Women have the normal reference range for a woman is really small. The lab will say up to 45. For a guy, it's up to 1,000. So the women only need about a 10th a dose of what a guy would typically take. So for women, their testosterone is not FDA approved for women in the United States currently. It is in Australia, parts of Europe and everything. And here it is not. Why? Because the first patch for women that was submitted to FDA for approval was in 2004 at the lab of the Women's Health Initiative when all hormones got a bad rap. So they shot it down. It's never coming back. Well, hopefully something will change. But again, getting medications approved, releasing it into the market is also a business decision for the pharmaceutical industry.
So how do people take, is it injection for women?
So there's a few alternatives. There is an injectable alternative. With injections, the levels kind of peak and fall a little bit between shots, typically weekly. So I prefer a product where they can stay a little more uniform and consistent. So I like oral testosterone for women, where the dose can be titrated carefully and can be tweaked. I like a product like that you can tweak. Pellets have been popular in women. I offer those. Everything starts conservatively. We start slow, see where they are, how they like it, and things like that. And then a lot of these women that get started on testosterone, estrogen or progesterone are able to come off their antidepressants. They're able to come off a lot of other medications that they may be on.
That's great.
Lipid parameters improve for women that are started on estrogen during perimenopause. We see that a lot. So if they have a statin prescribed either, so you can make a good case for either not prescribing a statin.
It's not contraindicated.
No, it's not.
Okay.
It's waiting to see what lipid profile, how it behaves in response to estrogen therapy, and then taking it from there.
So let me ask you this, and unfortunately we're running out of time. We could talk for another 2 hours. It's such a we may have you back because it's really a fascinating topic. We could delve in. This is just we're scratching
just
the
like the whole sexual.
But what I want the audience to understand, if there are women watching this who would like to come to your clinic,
yes,
I want them to understand what they would expect. How would that visit go?
Yeah.
What would they expect on the first visit? How would all this go? So someone comes in, they're having some of the symptoms that you've discussed.
Yes.
Whether it be hot flashes, sexual dysfunction, discomfort with sexual intercourse, etc., whatever it may be.
Right. Yeah.
Tell me how this goes.
Yeah. So I think we're first talking about it. What brings you here? What is going on? I'm here to listen. All ears, all eyes. So they're talking about their sexual dysfunction, when it started, how bad is it, how has it affected their partner relationships. And, we are here. We're having a very open discussion at that point. And then I'm viewing it for a woman that's in her 40s that comes with these symptoms. I'm viewing it through the lens of menopausal transition. A woman that is in her 30s, not necessarily so. They could be psychosexual, social factors that are intermingled. But for a woman that's coming in her 40s, I'm looking at it through the lens of, is this menopausal transition? So based on how they say in my head, I'm categorizing it into, is this an estrogen-driven symptom? Is this a progesterone-driven symptom? Is it a testosterone-driven symptom? It really helps me look at it like that,
right?
Because those are the three key players. And then diagnosing menopause does not require labs. If they fit that age profile and if they have hot flash, you don't need labs. But a lot of patients almost feel incomplete without, it's like the stethoscope effect, right? So you want to do something, get labs. So that's fine. I'm happy to get labs. For testosterone, it does become necessary to get labs because I want to see where they are at. And we talk about the different options. Before looking at labs, I talk about the different options and how it can be done. I'm also talking about the risks associated. And for some, I may have to spend a longer time sort of debunking a lot of those myths that they have carried with them. And then after the labs, we come back and then we talk about what's bothering you the most. How do we target that? Do you want all issues to be targeted simultaneously, or do you want to take it one after the other? Clear expectations are set with each hormone and what it can do to you. There's a brief overlap, but the effect of each, thankfully, is very unique. So it becomes easier for me to explain as a treating physician. For the vaginal symptoms that we talked about, not the systemic, but very particular, vaginal application of hormones is the way to go. So because the systemic hormonal applications don't penetrate the vaginal mucus in sufficient quantities. So we do vaginal application of hormones, testosterone, estrogen, various combinations. Again, testosterone is off-label, but so is 25% of medicine that you and I practice, right? Like trazodone for sleep is off-label, gabapentin for back pain.
For depression.
Yeah, exactly. So,
Off-label, then insurance doesn't cover.
yeah. So the estrogen, great question. So testosterone and estrogen and progesterone, the prescriptions go through insurance very easily. For testosterone, correct, it's not. So we basically use an FDA-approved product for men, and then we use a fraction of the dose.
Okay.
So it can be done in the oral form, pellets, creams.
Yeah.
Again, the profile, the risk profile, the patient profile really decides that for me.
Does it tend to be very expensive if a woman requires testosterone?
Affordable. What I've seen so far, it seems very affordable.
Small dose, so I would think
Yeah.
it would be.
It is, yeah. And the other thing to also note is that, interestingly, in women, they have sexual dysfunction. When you only give them estrogen and progesterone without testosterone, the estrogen and the progesterone can actually fight the testosterone that they're naturally making. So it can oppose it and make their sexual dysfunction even worse. So it's important to
balance.
tell them that and say, we got to balance it out.
Yeah.
But testosterone alone can be given without estrogen and progesterone. That's fine. But if you do those two, you don't want their sexual health to suffer
Exactly.
or their T levels to decline further. So there's all those very complex things.
You know, it's funny. When I was in medical school, I did an OBGYN rotation. There was an older obstetrician and obstetrician gynecologist, and he talked about giving testosterone to women for sexual dysfunction. And a lot of the other OBGYNs thought he was kind of nutty, but he probably was like ahead of his time now that I think about it, because this was, back in
1920.
Let me think about this. It would have been 90, 91, 92?
Yeah.
1992. It was 1992. Interesting.
It is, yeah. And I have some surprise feedback from patients that are on testosterone. Their sexual health improved, yes, but they came back, Doc, my eyes are not dry anymore.
Yeah.
My migraines are gone. Like some surprise effects, which there is when I then dove into it. There's some literature citation
Interesting.
of dry eyes and menopause.
Yes.
Probably a testosterone deficiency.
It's fascinating.
No, so I'm learning too.
This has been an absolutely fascinating conversation. I think we will have you back. We're going to do part
Absolutely.
two because
Yeah.
we just scratched the surface.
We need to.
Yes, absolutely. Yes, and I think conclusion. What I want to say is
That's what I was going to ask. What's the message
okay.
you want to leave?
I think in the 1900s, the average lifespan was what, like in the 50s? So now what people live up to the 80s, perhaps. So but I think back then, the biological clock of a woman also ended when the life expectancy was around 50. But now they are living another 30 years.
Sure.
Where the biological clock really hasn't adapted to it. So, it's sort of the second act.
Yes.
Yeah.
Make that count, and
let's enjoy it.
it ain't over till it's over. So
Right.
I think the goal is to prolong the sex span. I made up the term to reach your lifespan.
That's going to be the title of our next podcast, Dr. Lakshman. Let's talk about your sex span.
Yeah, and I think women should own menopause, talk about it to their partners as well, because partners don't talk. If a woman's uncomfortable talking about it, why would the guy talk about it?
True.
So
I don't know if women associate all these things just with menopause.
Yeah.
You know, it's hot flashes.
Yeah.
I mean, I think most people think about hot flashes and
Yeah.
sleeping. And,
It's not this whole entire list.
But we've got,
exactly.
heart discomfort, heart
Like
skipping,
everything's interrelated.
depression, irritability, anxiety, physical and mental exhaustion, impaired memory, sexual problems, which we discussed about bladder problems, dryness of the vagina, joint and muscular discomfort.
That's big. Joint pains, rheumatoid.
Right.
Vaginal bleeding, breast
I just the
tenderness,
multitasking,
migraines, voice
you know?
changes, fluid retention, facial ear, dry eyes. People don't think about
Like,
it.
no.
So the message I'd like to leave everyone is, because this is such an important topic, and I never really leave a message at the end, but my message would be to those watching this: if you have a friend or a family member or yourself, and they are suffering in silence, you don't need to.
Exactly.
There's help out there,
Absolutely.
and you can visit Dr. Lakshman, have a consultation performed, and see what help can be offered.
Yeah.
And how do they reach you?
So they can call our office at 508-235-0481 or go on our website, www.primacare.com. And they can find us there too and send a message or a request for an appointment. And
We'll post that.
we'll get
Put it in the show notes.
Well, thank you so much. That was
You're
really.
so welcome. I love coming here, and
We'll have you back soon
Yes.
because we need to delve into this a little bit
Yes.
deeper. I
Yeah.
think we
Absolutely.
really just we'll do a part 2. We scratched the
Yes.
surface.
I completely agree. There's a lot more to talk about.
Absolutely. I mean, we can go on, and we will. We'll do this again.
Yes.
So
Okay.
at this point, I'd like to thank everyone for listening to our show. And if you'd like to become a sponsor, please contact us at 774-319-4230. And special thanks to Ron Gamache for our intro music, Primacare, your trusted medical providers in southeastern New England. And the Bioskills of Northeast for producing our show, and available to produce your show by calling 774-301-8811. And they do a great job. So please, if you are looking to have a podcast of your own or move your podcast to another studio, this is a great place. Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. And for more information, visit their website, duncanhearing.com. And of course, Dr. Lakshman, thank you so much.
Thank you so much.
My pleasure.
This was so informative. I can't imagine that everyone listening to this did not learn a lot. I'm sure everyone did learn a lot.
I'm so happy to hear that. Yeah.
Thank you, everyone.